We first want to thank the American College of Physicians for the opportunity of presenting this poster at the Illinois Northern Chapter Poster Competition of 2021. This poster details a case of a patient admitted to the Jesse Brown VA Medical Center in December of 2020, and it's titled Blastomycosis, a real pain in the neck. Blastomyces dermatitis most often affects people living in regions bordering the Mississippi and Ohio River basins, as well as the Great Lakes of North America. Extrapulmonary dissemination in skin and bone is a possible manifestation. Cases of pyomyocytis due to blastomycosis are uncommon, and isolated muscle involvement is even more rare. This case starts with a 55-year-old Chicago man with a history of sarcoidosis on azathioprine. He presented to urgent care with a left-sided neck mass and pain lasting 3 days. A CT scan of his neck revealed a 1.3 centimeter left sternocleidomastoid muscle mass concerning for abscess with overlying cellulitis. An aspiration attempt was unsuccessful, so empiric treatment with clindamycin and dexamethasone was initiated, given the most common etiology of pyomyocytis is staphylococcus. 1 week later, he presented to the emergency room febrile with worsening swelling, pain, and purulent drainage. A CT revealed the mass was now 2 separate enlarged intramuscular collections. Vancomycin, levofloxacin, and doxycycline were initiated for broad coverage of a suspected bacterial infection, including possible cervicofacial actinomyces, given his history of immunosuppression from sarcoid and azathioprine treatment. Incision and drainage were performed with cultures growing only staph epidermidis and Corynebacterium, which were thought to be likely contaminants. 2 weeks later, he was admitted to the hospital with increased drainage and little to no improvement of the neck mass. The differential diagnosis was now broadened to other infectious etiologies, including fungal infections, as well as non-infectious etiologies, such as sarcoidosis and malignancy. His urine blastomyces antigen test returned weakly positive, but notably below the limit of quantification. Biopsy revealed thick-walled, broad-based budding fungus, diagnostic for disseminated blastomyces. Itraconazole was initiated, and over the next several months, near complete resolution of the abscess was observed. Further history taken in the clinic revealed that several months prior to his initial symptoms, the patient was helping a friend move bales of hay. This case adds to the rare case reports of disseminated blastomyces as an etiology for pyomyocytis. Even with more common presentations, diagnosis of blastomyces is often delayed. Studies from endemic regions indicate at least a 1-month delay in almost half of cases. Most patients are tested only after hospitalization. Additionally, extrapulmonary manifestations of blastomycosis tend to have lower urine antigen levels. These cases are more diagnostically challenging, as the urine antigen may be negative or below the limit of quantification, as it was in this case. Clinicians should maintain an index of suspicion for blastomycosis in endemic areas. Biopsy is the gold standard for diagnosis.